Okay, in the same series, we was discussing about the osteology in anatomy. I'm going to discuss a very important bone of upper limb which is known as clavicle. Clavicle's Latin word clavicle means the key shape, okay, like key shape, okay. It is also be seen as a F-shaped italic letter. This bone is clavicle bone. Where it is situated? It is situated in the collar area. Okay, collar area. Okay, this is also known as collar bone. Collar bone. This bone having many peculiarities. Many peculiarities. Number one, this is a long bone. And as we discussed, I want to remind you the features of the long bone. The long bones are usually vertically placed. Yesterday, we discussed about the humerus, which was vertically placed, radius ulna, vertically placed. Okay, the femur, vertically placed. But this bone is horizontally placed in the body, so that it become more and more prone for the traumatization or trauma. This bone get fractured easily. Number second, that is, this bone is transferring the arm weight or upper limb weight to the axial skeleton. So, any sudden jerk to the upper arm and sudden transferring of the weight can cause the damage to this bone, that is known as clavicle. Okay, and when we talk about this bone, there's some first of the protocol of the long bone is broken by this bone, that is horizontally placed rather than vertically placed. Long bones are vertically placed. Two ends, okay, it's have two ends like the long bone. Number three, one primary center for a long bone and more than two or more than two secondary center. But this having two primary center, okay, is start to ossify here and here. This part is cartilaginous in development, this part is membranous in development. Okay, we will discuss later on about this one. Sometime a nerve passes between this one. The middle division of the supraclavicular nerve passes through this bone. How it happens? Whenever there is a starting of ossification of the clavicle, nerve passes through this one and ossification occurs surrounding the nerve. So, there may be passing of the middle division of the supraclavicular nerve through this one. This supraclavicular nerve coming from the neck and passing through this one, the middle division especially. And this having two primary center, this is the long bone, which is, and it's not having a two border and two surface, three border and three surfaces like other bones. It's not having three border, three surfaces like other long bones. Okay, so this is different from the long bones, but it's a long bone. It having some peculiarities, horizontally placed, two primary center, etc. Okay, and these all having a clinical importance. Okay, now we are starting about the description of this bone, that is clavicle. This clavicle is situated in the collar area. We know this is situated in the collar. This is also known as beauty bone. This is known as collar bone, etc. How it's articulating? Oh, look at this one. This is the sternum. The medial end of this bone, look at this. This is the medial end of this bone. This is a quadrangular shape or rounded shape, quadrangular shape. This is the sternal end because this is articulating the sternum. This end, which is flat end, okay, look at this end. Look at this end. This is the flat end. This is the flat end. This end is articulating with the acromion process of the scapula. Acromion process of the scapula. So this is known as acromion end. You can say this is lateral end because scapula is here, and this is the medial end. Medial end, sternal end. Lateral end is the acromion end. Okay, like the other long bone, it's having two ends. But when we're talking about this one, for the purpose of a study of this bone, we have to divide it in a medial 2/3 and lateral 1/3. One thing is clear, this is the medial end, the adjacent area is medial one, and this is the lateral one. How we divide this one? Because there is this sudden change in a curvature. This convex part, which can be seen by anteriorly, and the concave part, lateral part, is separated. So there is a sudden change in the curvature. And due to this, again, another factor why this bone breaks, and is usually break where there's a turning of the curvature. Usually turning of the curvature. Okay, I told you two things are very important in the study of the bone. Number one, what is the holding, how we are holding this anatomical position, or the clinical relevance of this one. Okay, if I want to hold this bone, You know, this is the horizontally placed, this is the medial end, and this is the lateral end. Okay, can I hold this one here? Yes, I can hold like this. This is again a lateral end, this is a medial end. Okay, so is it a bone of right side? Okay, but there is a rough inferior surface. Look at this. There is a tubercle and a ridge. There is a pit here, and this is the groove here. So this is a rough surface, and this surface should be inferiorly placed. Look at this surface. It's a very smooth surface, very smooth surface. So this is superior surface. Why this? Most of the time smooth surface are subcutaneous. Okay, you can feel your clavicle like this. This is the superior surface. Two things very clear. It's a sternal end, it's a acromion. Smooth surface above and rough surface below. Still I can manage this one, but okay, I can manage like this one. But one more protocol, the medial 2/3 should appear convex from the front. Look at this. The medial 2/3 should appear convex from the front. Lateral 2/3 should be appear concave from the front. Okay, three important points. If you are forgetting even one, you may make a mistake in the examination. Sternal and medially, the acromion and laterally, smooth surface above, the rough surface below. Okay, medial 2/3 anteriorly convex, posteriorly concave, lateral 1/3 anteriorly concave and posteriorly convex. That means vice versa. Now I can't hold this bone like this. Any of the protocol will be broken by this kind of holdings. Okay, so this bone is belongs to this side, that is of left side bone. Again, this is articulating with the left side of the scapula. Okay, now we determine the site. We talk about the peculiarities. Now we are coming how we are going to study to this bone. We are going to study this bone into medial 2/3 and lateral 1/3. Why we are going to this study? Because both are developmentally separate. Both appearance is separate, development is separate. Okay, so we are going to study this one, and we know during the fracture, most common site to get fracture is this one. Okay, when we're talking about the flat surface, this flat surface having a one end that is known as acromion end, anterior concave border and posterior convex border. Look at this one, anterior concave border and posterior convex border is there. Okay, and if I'm talking above, that is smooth. If I'm talking below, look at this. This is the tubercle, and this is the ridge running anterolaterally from this tubercle. Okay, this is the tubercle and the ridge is running anterolaterally from this tubercle. This tubercle is known as conoid tubercle, and this is known as trapezoid ridge. Again, I'm articulating this one. A ligament, look at this, a ligament from this coracoid process, like my finger, from the coracoid process, a crow beak-like appearance coracoid process, up to this zone attached, and this ligament totally known as Coraco-clavicular. As its name indicates, from coracoid process up to the clavicle, Coraco-clavicular ligament. This ligament have two parts, one which is attached on the conoid process, that is known as conoid part, another this is known as trapezoid part. Is it clear? Two parts, conoid part and trapezoid part, expansion and tubercle. Okay, but totally these two parts club to form a one ligament that is known as Coraco-clavicular ligament. Inferior surface is over. No other attachment on this surface, that is known as inferior surface, conoid, tubercle and trapezoid. Above this is subcutaneous. Anteriorly, look at this, and this information will definitely help to remember something. Look at this. If it's articulating this one, this complete surface, concave anterior surface. Look at this, concave anterior surface. This is concave anterior surface. the lateral border of the acromion process and inferior border of this spinous process continuously give rise to a muscle which is covering the shoulder, and this muscle is known as deltoid. So if I am talking about individually to this anterior border of this lateral two-third of the clavicle, look at this, there is origin of deltoid muscle, and this is known as clavicular fiber of deltoid. We look at this one, this is the continuity. You can remember, this is the continuity, the clavicular fiber of deltoid, the acromion fiber of the deltoid, acromion fibers of the deltoid from his one, and this margin, the lateral border, acromion process is continued with the inferior. So continuous. Can you remember and write in my box where this deltoid is inserted? Okay, origin, anterior, concave margin give origin to the deltoid. Posteriorly, again we can find out posteriorly from here to here, upper margin of the spinous process, there is attachment of the trapezius. So two things are there. One is deltoid, another is trapezius. Anterior and posterior belongs to the anterior and posterior border. Now this lateral 1/3 attachments are over. This is the, if I am talking about the lateral end, this is having an attachment of synovial membrane or capsule, which is forming the coraco-acromion joint, sorry, clavico-acromion joint, acroclavicular joint formation. And I'm talking about this medial 2/3. Let's talk about the medial 2/3. This is medial 2/3. When we talk about the medial 2/3, there is the upper smooth surface and there is the inferior rough surface. This is sternal end. When this articulating like this with the sternum, in between these two clavicles over the sternum, there is the intraclavicular ligament. Intraclavicular ligament. In between two clavicle, intraclavicular ligament. Okay. Second capsule is attached. From the lower part of this one, we can see here is a pitting. Here is a pitting. This is the pitting area. This is giving attachment to the costo. Costo means first costal cartilage below this one, clavicular ligament. Okay. Above there is interclavicular ligament between two clavicles. This is name indicate. One clavicle to another clavicle. In this order, this is crossing the sternum. Costoclavicular ligament below. Okay. The anteriorly there is a flat rough area. This is the flat rough area. This will give rise to, anteriorly this is a flat rough area. This will give rise to the pectoralis major muscle. Okay, pectoralis major is very vast muscle. Very vast muscle. So anterior 2/3 is giving rise to anterior 2/3, lateral, medial 2/3, anterior surface give rise to only and only the clavicular fibers. Other are sternal fiber, fiber from the external oblique. Again, write in my box if you are preparing well. Kindly write in my box pectoralis major inserted there. And we discussed in the previous session, so that the complete adjustment and attachment of the pectoralis major can be remembered. Okay, so this is the pectoralis major. Okay, not only that, just lateral to this there is a groove. This is a groove, and this groove having attachment of a muscle which is arising from the first rib, attaching there. This muscle is subclavius. This muscle is known as subclavius muscle, and surrounding the subclavius muscle there is attachment of the clavipectoral fascia. Never ever forget, whenever anybody asking about the subclavian groove, you should remember attachment of fascia around this one, that is known as subclavius clavipectoral fascia. Okay, when we talk about this one, medial, at the medial part and this surface, just superior surface, there is attachment of the sternocleidomastoid. Sternocleidomastoid. A little posteriorly there is an origin of sternohyoid muscle with the capsule. Sternocleidomastoid, sternohyoid. Okay, the medial end throughout the superior surface, rest of the superior surface is smooth, and you can feel it. throughout the superior surface is smooth. Why smooth? It's a subcutaneous. No other attachment is there. No attachment is there. Okay. These are the attachment over the clavicle, the lateral 1/3 and medial 2/3. Okay. The superior surface is subcut. The inferior surface costoclavicular ligament, subclavicular having the attachment of the subclavius muscle surrounding the clavipectoral fascia. You know, whenever you're reading, a clavipectoral fascia is very, very important short note, and you can remember that clavipectoral fascia is enclosing subclavius as well as the pectoralis minor. And it divides whenever there is a border of the muscles is there. Okay? Yes, you do clavipectoral fascia, and condensation of this fascia is coracoclavicular ligament laterally. Superiorly smooth, anteriorly pectoralis major, anterior superior surface gives the sternocleidomastoid at tendinous origin, clavicular head, and sternohyoid attachment there. You know, these are the attachment over the clavicle muscle, and these are very, very important muscle. This muscle is making a boundary between the neck and the thoracic region. That should be remembered. Okay. In case of a fracture of clavicle bone, due to the traction of muscles attached, you can see a clear-cut demarcation, and subcut you can feel where the bone is broken. In such cases, usually it's the scenario and the protocol is changing now, but a conservative treatment with the application of the 8 bandage is preferred. Still they try to put some plate, etc. Why they are avoiding? Because in relation to the medial part of this one, the lower trunk of the brachial plexus is passing. Subclavian artery is passing, which is going and outside at the outer border of this first rib. They are converting into the axillary artery, and several other important structures are going medial to the posterior to medial 2/3 of the clavicle bone. If you are trying to manipulate or doing some surgery in the clavicle, whether you should be good enough to avoid the injury to these structures, otherwise the result will be very, very devastating. Okay. So preferable management or treatment of the fracture of clavicle is 8-shape bandage. Okay, one more thing. Subclavian vein is going here, and sometime the cephalic vein is here, and sometime a communication between these may be there, which is crossing over the clavicle. Whenever the clavicle gets fractured, this vein can torn, and large hematoma with this bleeding can appear in front of the clavicle. These are few informations about the clavicle. I want to tell you, student, by my experience, I want to tell you, if you are not holding this bone properly by 3 protocol: lateral and flat, acrominant, medial and quadrangular shape, anterior 2/3 appearing convex from the front, medial 2/3 appearing convex from the front, lateral 1/3 appearing concave from the front, superior surface is smooth and inferior surface is rough. If you are escaping any point, you are holding the bone in the wrong position, and I want to tell you that is a bad impression to an examiner that you are not holding a clavicle bone, which is frequently it explained you as a first bone of your MBBS. Okay, so kindly go through this one, and whenever you have a occasion, hold this bone many times. Okay, left side, right side, as well as articulate. This bone articulate at acromion here and the sternal end on this side. So have a journey through this bone, academic journey through this bone, and find out the proper explanation of this bone. This bone may be the first one which is elevated, which is examiner may ask to hold this bone. And again, if you are not holding the bone in the position, probably your impression is used immediately. No matter of attachment, or no matter of attachment of bone and etc. clinical. Second most important thing, which is frequently asked, what the peculiarities over this long bone. This long bone is horizontally placed. There are two primary center, because by one primary center lateral end is originated, another primary center giving rise to this medial two-third. Both are separately originating, then fusing with each other and forming the clavicle. Okay, then sometime a nerve, middle division of the supraclavicular nerve is passing through this one, root value C3, C4. Okay, is not having the not having the three border three surfaces. The medial two-third having four border four surfaces, and I want to tell you, all the borders are not well demarcated, but surfaces: superior surface, inferior surface, anterior surface, posterior surface. Okay, and the lateral one-third having an anterior border, posterior border, superior surface, inferior surface. Okay, so both having different border and different surfaces. Okay, this was something about the clavicle. Go through the book and read the clavicle thoroughly. Happy learning, students. Kindly subscribe and like my channel for encouraging me to upload few more videos. Thank you.